we in a position to take the briefing from the ambulance service, Clerk?
Yeah, Michael's on there, so we're going to try and bring him up and see if the camera and the microphone's working.
Okay.
Hi, Michael. You able to hear us okay?
I can hear you. Can you hear me?
Yes, we can hear you okay, so we can.
Okay,
Yep.
Thank you.
Okay, Michael, your appearance is long awaited at this stage now, given the circumstances. But anyway, we're looking forward to the session with yourself. Do we have Rosie Byrne on the line as well, or?
With the apologies, Chair, we had some difficulty getting on at the time we were asked at 11 o'clock. We had it set up in a room that we're socially distanced, and it was on a camera mounted on the wall. You could see all of us, but we just couldn't get that to work. So we're on a laptop. So I've got Rosie Byrne, Director of Operations, and Maxine Patterson, Director of Planning and Performance, both with me. But I'm afraid you're just going to hear them and not see them. And I can assure you that's probably the poorer option. It might have been better putting the camera on one of them rather than me.
Okay, well, we'll work with it, but yes, and I'm certain that anticipation has seasoned the expectation, and that will be through the roof at this stage, Michael. So, good luck. Okay, so I welcome you all. I welcome you all to the committee this morning, and I'll go ahead back to yourself, Michael. If you would give us your opening remarks or remarks from Rosie or Maxine, and then we'll go to members' questions. Thank you.
Okay, thanks, Chair, and good afternoon to you and to all of the committee members, and thank you for this opportunity to brief the committee on the pressures currently being faced by the ambulance service. With your agreement, Chair, I'm going to make just a very few brief introductory remarks to allow almost all of the time for committee members to ask questions, which is probably more useful for you. So it'll just be me, makes a few introductory remarks, but I'll be certainly looking to Rosie and Maxine to come in and pick up on some of the questions. We sent you a couple of documents, and they were just by way of background only. That was our most recent performance report presented to the NIAS Trust Board in October, which provides some detail on the pressures that the service is facing and the actions that we are taking to address those, and also the Trust's COVID surge and winter resilience plan that we submitted to the department. We don't intend to talk to either of those documents in any detail, but they may contain information that is useful to you to inform the discussion. We last briefed this committee almost exactly this time last year, and it's been a particularly difficult 12 months since then. I would say the last 4 to 5 months have been the most challenging period that the ambulance service has had throughout the whole pandemic, and there are a number of reasons for that. Firstly, our demand has now returned to pre-COVID levels, and in fact, it is now higher. We received 13% more 999 calls in October 21 than we did in October 19 before the pandemic. Secondly, we continue to have a large number of staff unavailable for work. At any time, we have approximately 20% of our operational staff who are unavailable to work, either through what might be considered normal sickness absence or COVID-related reasons, such as the need to self-isolate. And it's roughly equal in terms of the numbers for both ordinary sickness and COVID-related absence. So this makes our service even more reliant on staff working overtime in order to provide the required level of cover. And that's simply unsustainable. It's been well said by all organisations, about all staff groups, that staff are exhausted. I feel that's almost become said so much it's losing its impact, but it really is the case, and we cannot expect our staff to keep working at the level that they have been over the last number of months. And then thirdly, the wider unscheduled care pressures across the system that have been well documented have resulted in increasingly long delays in handing patients arriving by ambulance over to emergency departments. On average, around 20% of our emergency ambulance capacity is lost every day waiting outside emergency departments to bring patients in. And obviously that makes them unavailable to respond to calls waiting in the community when they're doing that. Many of our crews now would only respond to 1 or 2 calls during a 12-hour shift. Before the pandemic, that would have been between 6 and 8 calls during a shift. So these factors are all leading to increased response times for patients waiting for an ambulance in the community. Response times in particular for categories 2 and 3 patients, and those are very, very ill patients. Category 1 is the very small number who've got an immediately life-threatening condition. Category 2 and Category 3 are still very ill patients, and the response times to those have increased significantly over the last year. And finally, it's also having a very significant impact on our staff. They continue to do the very best they can, but I know that they are concerned that they are unable to provide the standard of care that they want to and that people need, frankly. They also experience regular late finishes to their shifts and late or on occasions no breaks during a 12-hour shift, things that are of a real concern to me and that we're trying our best to address. And that's all taking its toll on our staff. And I really do want to take this opportunity to place on record how grateful I am to them for everything they continue to do to try to provide the best care they can in extremely challenging circumstances. They're an extremely dedicated group of healthcare professionals who serve our community very well. So thank you, Chair and committee members. That's all I wanted to say by way of some introductory remarks, and we're obviously now very happy to try to answer your questions.
Okay, thank you, Michael. So again, I'll rattle through the questions fairly succinctly because we do have a fair bit to cover, I suspect, and I want to give everyone as good an opportunity as possible. So a few of myself first, and then I'll go to members and other members. So in relation to the workforce, how many staff do you think you're going to need in over the coming months, or how many staff do you think you're down in relation to what you need over the next coming months?
Well, we don't have sufficient staff to meet the demand in ordinary circumstances. I think I probably reported that previously, that we had an independent review carried out that showed we need an extra 325 operational staff and other corporate support staff to deal with such an increase. So we still very much need that. But the fact that we're down at any point in time 20%, now there'll always be an element of sick absence, a background level. We had got our sick absence down to about 8% about a year, 18 months ago. And you have to always plan for a certain element of sickness. Their staff will be sick. But when it's sitting at 20%, that's what makes the delivery week in, day out of providing an appropriate level of ambulance cover very, very difficult. I don't think that is likely to change over this winter with the number of people who will have to self-isolate at any time, particularly given concerns about new variants and so on. So we will need over this winter time to continue to rely on the staff who are able to work to do a little extra in terms of overtime, and we will continue to make use of voluntary and private ambulance providers to also make up any gap. But longer term, we continue to need in the order of over 325 staff to provide the satisfactory level of response time right across the region.
And linked to that, Michael, you've mentioned in your performance report that training programs have had to be interrupted twice as a result of COVID. So what impact has that had on delays to training and on delays then into staff feeding through into the service?
That was one of the most difficult decisions we've had to take, Chair, during this. Staff who had applied for and commenced a foundation degree in paramedicine, who are our existing emergency medical technicians, and interrupting that to put them back out on operational shifts. I have to say they did it extremely willingly, but they were clearly disappointed. That did have a knock-on impact. So the current cohort of foundation degree students, they're not due to graduate until January. That would have been around the summer time. Otherwise, we then would have started the fourth cohort in August. And there was always the requirement that we had to do any in-house paramedic training by September 2021. At that stage, the HCPC changed the regulations and it moved to the new BSc, which has started up at UU in September. But we got permission from HCPC to extend that to March because of the pause. So we are still planning to commence a fourth and final cohort of foundation degree paramedic training in February to be in before that March window, because that really is the last one. So it has delayed the timing for having those paramedics in, and it's that tension and that balance that we have to manage between today's pressures and today's problems, as opposed to having the right number of staffing in a year's time. And we've tried to strike an appropriate balance in that. All of the training is has been back in now for quite some time, but there has been a delay as a result.
Okay, thank you. And the southern region, Michael, has a long history, and I'm well aware, and I'm sure other representatives are, a long history of poor and inadequate staffing levels. Is there, and I'm not asking this question from an insular perspective either, because the impact of that then is that very often staff have to be drawn in teams from other areas, leaving cover scarce more widely across the region. So have those, the reasons why that's historically and continues to be the case, been identified, and is there anything in place to try to address that continuing weakness, it would appear?
Well, I'll ask Rosie Byrne, Director of Operations, to say something about that in a moment, Chair. But we don't have a understaffing position in the Southern Division. Actually, the division at the moment that we have most difficulties in staffing is the Southeastern Division, which works very closely with our Belfast Division, but it does cover obviously large areas like the Ards Peninsula and down to Newcastle. The Southern Division, we would aim to put out in the Southern Division around 13 or 14 ambulances each day shift, and slightly less at night. We have difficulties at different times in each division, and there have been times when the Southern Division has been affected. That 13 or 14 ambulances across the whole division includes, Craigavon, Dungannon, Armagh, Newry, Kilkeel. It's a wide area, and each of those would only have one or two ambulances operating out of them. So what tends to happen is, if you've got a number of staff off sick on a shift, that's when you hear stories such as there are no ambulances working out of a particular station. But we manage the division as a whole, and indeed then we manage the services as a whole, and bring in the ambulances, the nearest available ambulance to respond to a call. But that undoubtedly, again, does mean the crews are being stretched and journey times are longer. But I will ask Rosie if there's anything particular you want to say about the Southern Division.
Thank you, Michael, and thank you, Chair. As Michael has said, I personally wouldn't have chosen the Southern Division as one to pick out as an outlier in staffing. But as Michael has very clearly articulated, we do rely on managing the division as an entire division. We do rely on cross-divisional cover for our co-terminus areas to provide cover, where we have times of peak drops in demand, or drops in our capacity, I should say. We also then rely, as Michael has said, on our independent providers. We have also moved some of our PCS crews over to provide A&E support, not just in Southern Division, across all divisions, because our acute hospital trusts have changed how they manage their, for example, outpatient activity. So we've prioritised some outpatient activity for key conditions such as cancers, red flags, dialysis, etc., to supplement A&E support. So we look at it across our A&E support, our PCS support, and our independence to maximise the cover that we can.
Okay, thank you. Yeah, and I suppose it could be a factor that where I'm located means I'm picking up on that sense, but I do pick up on it over a period of time. I have picked up, but I'm reassured to hear that that's not actually the case. The final one from me then, before I move on to other members, is around critical incidents or adverse incidents maybe. Have there been adverse incidents over the past number of months that you're looking at when a crew weren't available to carry out CPR? And do you monitor and measure, are those on the increase, or is there any trends around those adverse incidents, Michael?
Without a doubt, Chair, the increase in response times over the last year have led to an increase in complaints and also serious adverse incidents. Now, it is difficult to put a precise cause and effect relationship, because we in the background have also been, over the last couple of years, really encouraging our staff to report adverse incidents. There was previously quite a low level of reporting of serious adverse incidents in the ambulance service, and we are keen that they are reported and the staff learn from them. We all learn from them. We make changes, and that it is, there's no worry from staff about reporting them in terms of thinking there'll be blame, etc. So it's quite difficult when you are encouraging reporting and then you see an increase to link that directly to response times as opposed to increased awareness. But I think it's fair to say, given the nature of the incidents that are being reported, we are seeing an increased number of serious adverse incidents associated with delays in us arriving on scene. These are time critical incidents. There's a reason why there's a response time of 8 minutes for a category 1 call and 18 minutes for a category 2. They're not arbitrary. They're there because that gives patients the best outcome. And if we are taking much longer to get there, there is, of course, a risk of increased harm, and that in some cases feeds its way through to serious adverse incidents. I think Rosie might want again to add some specifics to that.
Thank you, Michael. Thank you, Chair. So I would just reassure committee that we do have mechanisms in place for investigations, both of our complaints and our SAIs. When we receive complaints, we, if they are directly linked to delay in response times, we have a weekly meeting whereby we review all our complaints and our SAIs. I have to say we do review our compliments at that weekly meeting as well, but we review all our complaints and our to determine whether any of them are potential serious adverse incidents and if they meet the criteria for that. So I think it would be wrong and it would be kind of too simplistic to say that SAIs are all the result of delayed responses and delayed handovers. But we have a robust mechanism in place whereby we look at all of those and, as Michael has said, take the learning from them as to how we can improve and reduce the poor outcomes that could be attributed.
Okay, well, could you maybe send us on a breakdown of how many have been progressed to an SAI level, say over the past 12 months, just so we get an idea of how many we're talking, and kind of that's something we can keep an eye on in that sense.
Yep.
Okay. Yeah, thank you, Michael. And I'm going then to firstly to Colin, then Paula, then Pam, then Deborah. So go ahead, Colin, please. And Carol, sorry, I have Carol then as well. So back to Colin.
Thank you very much, sir, and thank you to Michael and the team. I just want to say that I'm always amazed at the work that our paramedics and our full ambulance team do. You work under very, very difficult circumstances, and I've met with you before, Michael, where I've said, if it was me, I would double your budget. I would want to see double your staff and complement. I would want to see a fully enhanced ambulance service, because if we can get the people when they're needed most, and then get them prioritised and triaged and into the care in hospitals, I think that the community would feel a lot safer. Michael, you mentioned, and so just on the budget, if my memory is right, the budget for ambulance service about 50-something million out of a 6 point something billion budget that we have for our health service. Yet increasingly you're becoming the front step, you're becoming the first place where a lot of people are interacting, and you're under a lot of pressure. But I know that there's workforce issues that you need to work through there as well. But
just on that, Colin, and thank you for your comments and your support, which we obviously welcome. Our budget is modest, but thankfully it is a bit more than that. We've got about a £90 million recurrent budget, and we have been consistently getting over 10 million non-recurrent each year. So we operate with around about 100 million, of which about 90 million is recurrent. We need a significant uplift in order to provide those 320 staff that I mentioned to the chair.
Yeah, and you mentioned earlier, and I missed just the figure that you had said because of the sound quality. But what I mean in terms of the response times, which are increasing, what is it that's causing them, and what was that percentage that you gave in terms of the amount of time that people our ambulances are waiting at hospitals?
Yes, I mentioned three things that are all driving the increasing response time, Colin, and that is an increasing demand. Now, we've got to remember that demand fell considerably during the early days of the pandemic, and we are now seeing it completely back at pre-pandemic levels. So that's one. The availability of our staff is clearly the second. If we don't have enough people to fill all of our shifts every week, that impacts on response times. Actually, across the working week, our cover's not bad. We're usually about 94, 95%, but there's big drops and big differences in certain areas on certain days and certain shifts. So you might see a Saturday night in a division where it's only 75%, but it averages across the region at 95%, and that's only by staff working a lot of overtime. The factor that is making the biggest or having the biggest impact on response times currently is the amount of time we are losing that we cannot respond when our ambulances are waiting outside emergency departments to hand over their patients. That is a direct result of the pandemic. We still had handover issues before the pandemic, but our staff would have queued in a corridor and they would have doubled or trebled up. So if I arrive with my patient and an ambulance arrives after me, I might look after their patient as well. And you're in a hospital setting, and that was done. Not ideal, but it was safe to do so. We can't queue in hospital corridors since the pandemic. So if the hospital is so busy, which they are, and I know the reasons for that, and I know the challenges and the pressures that my colleagues in the other acute trusts are dealing with, if that means that they simply have no room to take anybody in, our staff wait with the patients in an ambulance. And the figure I gave is that on average, every day we lose 20% of our capacity to while waiting outside in ambulances. The average delay in the month of October was 1 hour and 13. It should be 15 minutes to hand over a patient. The average delay in October was 1 hour and 13. Every day of the week, there will be patients wait 4, 5, 6 hours, and on rare occasions, there are patients who wait longer than that. That led to the other figure that I mentioned, that whereas a crew who came on and do a 12-hour shift, the last time I went out with a crew was before the pandemic, and I worked a 12-hour shift with them, as did Rosie. And you go to 6, 7, 8 calls, you see a good variety of the types of issues they deal with. Now, in a 12-hour shift, our crews typically do 1 or 2 calls, and they spend the rest of their time waiting. That's hugely frustrating for them, and it's also impacting, obviously, on people who are waiting. And there's other issues. We have, the chairman asked about training. We have got paramedics in training at the minute who spend a lot of time out on placement. And if they're only seeing 2 calls during a 12-hour shift in placement, they're not getting the same level of experience and learning as they would if they saw 6 or 7. So it's taking them longer to see the full breadth of conditions that they will come across.
And of course, the ambulance sitting outside an emergency department is predicated on that emergency department being open. And we had the experience there recently where Craigavon had to actually close its doors and not take any of the calls and implement a bypass because of the pressures that they were under. I mean, can you talk us through what happened there, the impact of that upon your service in terms of diverting ambulances further away? And I mean, were any lives at danger as a result of that?
Well, it's probably important to say, Colin, that every day of the week, our control room do what we call smoothing, and that's in agreement with the other trusts. So we will try to balance pressures. So if we see, as we do every day, an emergency department under significant pressure, we will take a conscious decision for a while to try to ease off there. And the patient condition always comes first, and there's some patients, doesn't matter how busy it is, we've got to take them to the nearest department. But we will do that moving to try to equalise pressures to some extent. On occasions, and it's rare, but it's what happened the weekend you're referring to, on occasions an emergency department is so under pressure, smoothing just isn't going to give them the release that they need, and we need to do something more to decongest that emergency department. Those are regional discussions and regional decisions taken. So we will have been party to regional calls, and we were at that weekend and leading up to it, where there was an agreement and an understanding across the system that in order to decongest Craigavon, that other EDs would need to take more patients. The only way there is to do that is to encourage walk-ins, people who self-present, to please don't go there, go somewhere else. And that is very difficult to change people's patterns and behaviours, or the ambulance service take them. So that was what was agreed that weekend. Only standbys, and those are the very, very seriously ill, category 1, who need resuscitation. Only standbys were to go to Craigavon, and for a large part of the Sunday, I think it was, and again on the Monday, we took patients who would have gone to Craigavon, we took them to the Southwest Acute Hospital, to the Royal, and to Antrim. You asked about the impact on our service. The impact on our service is that all of our ambulances, or most of our ambulances, who would have been within that southern division that the chair was asking about earlier, because they would have gone to Craigavon, been dispatched to the next call, most likely in the southern division area. They are out of division. When they clear at a call at, let's say, Antrim, if they're the next available ambulance to go to Ballymena, they will be sent. They are not just sent back down to the southern area to wait. So it does mean that our ambulances are out of area for a lot of the time, and that obviously again leads to increased response times for people in that area. There would not have been the normal volume of ambulances within close proximity to calls if they required a very, very urgent call. There's a longer journey time, so that clearly has the potential to cause harm.
Michael, the chair loves one-word answers.
Very
So
briefly.
last question with a one-word answer. You mentioned severe or serious adverse incidents early. Maybe for people that are out there that don't understand what they are, they're the potential for people dying. Can I ask this question? With the pressures that we have on our system at the moment, from the health sector through to the ambulance sector, are people dying?
I can't give a one-word answer, Colin, because SAIs are not just about dying. SAIs are about potential harm. So it's more than dying. But are people dying? Well, we are aware of calls that have come in that by the time we get to the person, it is too late for us to help them. What we do not know, Colin, and I have to be clear on this and given the chance to say it, what we don't know is if we had got there sooner, would the outcome have been different? But certainly we are aware of calls that by the time we get there, it is too late for us to do anything about it. These are time-critical conditions. There's plenty of evidence and accepted research that delays in getting to somebody with a time-critical condition and then getting them to hospital for their definitive treatment, there's a link between delay and poorer outcomes.
Thank you, Chair. Thank you, Michael.
Thank you. Paula, go ahead, please.
Thank you, Chair, and thank you for the panel for the update this morning. My first question is really in relation to, I think it's that last point there around sort of the critical time factors. I'm just wondering, are any conversations taking place with the Fire and Rescue Service in terms of first responders, in terms of some collaborative work around getting to the house and maybe providing the support in the house that then that doesn't require them moving into hospitals? That's my first question.
Yes, thanks for that, Paula. And the short answer is yes. And if the chair likes short answers, I could probably stop at that. But the short answer is yes. We've had a very productive meeting with our fire and rescue colleagues, and Rosie was at that with me just in the last week, where we are exploring a range of areas where they could assist us across a range of conditions. That's at an early stage that I probably I'm unable to elaborate now without going through the proper processes and discussions, but very positive conversations that I would be confident there'll be an outcome from.
Oh, that's good to hear. I'm actually meeting with the new chief in the next week or so that I'll probably hear a wee bit more then. My second question is in relation to...
I'm fairly sure he will confirm that. Yeah.
Great stuff. My second question is in relation to your briefing, which outlined that you said there's the use, because of pressures, there's the use of voluntary and private ambulances to supplement capacity. Could you elaborate a wee bit on that in terms of the protocols and when that happens? Just a wee bit more information, please.
And I will ask Rosie just to take this one, Paula. Thanks.
Yes. Thank you, Michael. Thank you, Paula. Yes, so we have a service framework agreement in place with voluntaries and privates that allows us to engage with them across a range of calls. But we're quite clear on the calls that they can respond to, and we have quarterly meetings with the voluntaries and privates to make sure that there's adherence to the framework. And what we do first of all is obviously looking at our own NIAS resources and seeing if there are any drops in our cover from that and anything we can do internally to improve that cover. Then we look towards our own PCS tier to see what can provide A&E support. And then once we've identified the quantum of the gap, that's when we engage then with our voluntaries and privates to bring that level up to as best possible cover that we can. But it's to respond to appropriate calls in the community.
Okay. No, thank you, and I appreciate that, just that wee bit extra information. Just a very quick question last. We've had some presentations from a range of different sectors, and it's just around abusive staff because these are under so much pressure. I'm just wondering, do you want to speak to that around what the impact that has on your staff?
Yes, well, we see an increasing level of abuse against our staff, and quite surprisingly and very disappointingly, if that's not too mild a term, we've seen that increase during the pandemic. It has a huge impact. I try, or Rosie or a few other senior colleagues try to speak to every member of staff, and I'm always shocked when the response by most staff is, oh, well, it's just part of the job. And my response every time is, it is not part of the job. It is totally unacceptable, and it's always unacceptable. And we try to support them as best we can. But my frustration is there's quite a limit to what we can do, either to support them or to prevent it. We've had a very successful social media campaign over the summer, Stop the Abuse Now. Indeed, many elected representative colleagues contributed to that, and that was much appreciated by our staff. We are exploring the use of body-worn videos, and we'll be looking at how we might take that forward over the coming months in consultation and so on. And there are all sorts of issues around that from a GDPR point of view, but we are also looking at pilots around stab vests. But other than those sorts of issues and continuing to highlight it as an unacceptable issue, I don't know if Rosie has the numbers to hand, but it's in and around 400 or 500 a year. And the impact of that on some staff, the impact seems to be they are able to return to work quite quickly. For others, clearly it causes them real fear returning to work. And we've got a small number of staff who, after incidents like that, are unable to return to work, sometimes because of physical reasons, much more often because of the mental reasons. Rosie, anything you want to add?
Yeah, I've just come in to say that the assumption is, and it is a very worrying trend, but the assumption is that when we talk about abuse of staff, that it's ambulance staff on the road, but it's verbal and physical abuse of staff on the road, but it's also verbal abuse from our folk in the control room taking the calls. And you can understand that people are very frustrated when they're waiting on an ambulance and keep calling back, but we have, for both folk on the road and within the room, we have a range of staff support measures in place, including peer support, access to Inspire, and we have now a clinical psychologist on board that we're starting to work with to support our staff. We have developed welfare hubs where our staff, after particularly stressful calls, either on the phone or out on the road, have somewhere that they can go and have some downtime, and we can have a debrief with them. We staff who are particularly challenged, we have CBT arrangements, so we have a real depth and range of support for our staff, recognising the challenges that they are facing, unfortunately, day and daily.
Okay.
No, I appreciate that. Thank you very much, everyone.
Okay. Thank you. And just to clarify that the chair does love short answers, but even more loves succinct but complete answers and comprehensive answers. And I do understand that sometimes time doesn't allow that, but just to reiterate that if there is further detail that would be helpful for you to send on to us, or the members are looking, that can be done by follow-up in writing. So appreciate that from everyone. I also like succinct questions too, which is great as well. I'm going then to Deborah. Deborah, go ahead, please.
Thank you, Chair. I suppose a lot has been covered there, but I mean, I'm interested in hearing the thoughts in relation to McGee Medical School, and whether you think this will significantly help your workforce in recruitment and retention with, say, the Pacific paramedic courses, and also another question, does the ambulance service believe that their concerns and interests have been accounted for effectively as part of the regional planning and consultation? Thank you.
Okay, thanks, Deborah, I might ask you to elaborate on the second part of that, just to make sure we're answering the right question. In relation to the UU at Magee, the BSc, absolutely fundamental to the future sustainability, but also progression, professionalisation of the ambulance service here. We have got very, very capable, experienced paramedics who continue to serve the population here extremely well and will continue to do. But in line with other countries across, certainly other countries in the UK and Ireland, and other professions, the professionalism of paramedicine is essential, and the enhanced skills that can be got through completion of a BSc programme. I met, along with other colleagues, the new intake of BSc students up in Derry on their first or second day. And I have one of the most uplifting days I've had over the last couple of years. I've a long time since I've met such an enthusiastic group of young people who clearly have a long-held desire to be paramedics. We need to get the balance moving forward of how we continue to develop and support our own staff, and they can still, those who are not paramedics or those who are paramedics but not to degree standard can attain that, but also bring in people who are qualified to degree level. But the other key reason, those numbers I mentioned at the start of needing an extra 325 staff in the organisation, our hope is over the next 5 years. The only way we could do it is through the sort of volume that will come in through that programme. We would not be able to train that many staff ourselves. So it's both about numbers, but it's also about enhanced skills and enabling us to move into much more advanced and specialist roles that those people will be well equipped to do. And sorry, the second bit of your question, Deborah, about...
Yeah, so it was, do you feel that the Northern Ireland Ambulance Service have had their concerns and interest accounted for effectively as part of the regional planning and being able to feed into that process?
Yes, we are closely tied into all of the departments' work around looking at priorities, etc., for the coming years. I sit, as do Maxine and Rosie, on relevant groups. I sit on all of the groups that the department have, that all of the other trusts are on, like previously the Transformation Implementation Group, now the Rebuilding Management Board. It is, I believe it's very well understood by departmental colleagues and other trust colleagues of the absolutely central role that the ambulance service has in transformation. That if we are going to transform all areas of healthcare, if we don't have an ambulance service that's resourced to get to people quickly and bring them where they need to be, that's a big inhibitor in order to make transformation. I believe that's understood, and that the priority in resourcing the ambulance service is accepted. That doesn't mean it's easy, because there's such a long list of very deserving needs, and there's a finite budget, but there's certainly a good understanding. I don't know, Maxine, is there anything you wish to add from the whole planning, linking into planning?
I think you covered it very well, but just to be succinct, yes, we do sit in a range of regional planning meetings that we contribute to. We are able to voice the concerns of the ambulance service and ensure that our needs and our strategic direction is taken accounted for in all of those planning forums.
That's great. Thank you.
Thank you, Deborah. And Jerry Lanneray at all.
Sorry, Chair, Jerry's not on the call at the minute.
Okay, so I'll move to Carol then. Carol, go all right.
Thank you, Chair, and thank you, panel. It's really important that we heard from yourselves today. I just want to go back on some of the investment. I think we're going to need some more details on the investment into the independent voluntary aspect of ambulance service, because even just my own experience is that they're used quite a lot, and I'm wondering what the issue is, why they're used a lot, and what the issue is around workforce planning. So the other issue I want to talk about is, which has been highlighted in the media a lot, but certainly in the Royal Emergency Department, people are having to wait hours in an ambulance because of the demands in the ED. Have there been any discussions with the department or indeed any of the health and social care trusts to have other arrangements where the care of patients are still under ambulance, but ambulances can, within the hospital setting, and ambulances can be discharged to go to emergencies? And then my last question is, it's around, I do think we're going to need more details, particularly on the adverse incidents. So I'm aware of one case where someone died, and the family called an ambulance on occasions, and I have no doubt that if there is an inquest, the cause of death will come out, but it will need to be an inquest to establish if an ambulance or even paramedic intervention would have made any difference, because I don't know how anyone can ascertain that detail in absence of an inquest. So, and I also, in relation to the quality impact assessment, given the fact that rural areas have, there's a lot more to cover. So has the ambulance service done a full quality impact assessment given the increase in demand?
Okay, thanks, Carol. There's quite a bit in there. I'll try to pick up some. I'll ask colleagues to join a few brief comments. The investment in voluntaries and privates, the why, it's very closely linked to if we've 20% of our staff down at any point in time, how we fill that. So as Rosie mentioned, we try to get staff to work as much overtime. We look to see, can our non-emergency service do some emergency, and even if they can, their work needs backfilled. So it is largely backfilled. I want to get to the stage, I've said this previously, I want to get to the stage that we are self-sufficient. I don't know whether there'll ever be a point of time where there's not the occasional need for some voluntaries and private providers to fill a gap, but I would like it to be occasional, not every shift. And it's currently the position, because of the number of staff we have off, and until such times as we are able to recruit the staff that we are seeking funding for. The issue about delays at ED, you mentioned the Royal, but the issues are exactly the same earlier. Yes, there are hours that patients wait in an ambulance, and I said every day there's 4, 5 and 6 hours. There are sometimes longer. There are sometimes our crews come on and spend their entire shift waiting outside an ED with the patient in the back of an ambulance and don't go to a single call. Lots of discussion with the department and trusts, and indeed the permanent secretary issued a letter last November, just over a year ago, being very clear on the responsibility for this lay with the other trusts to take patients off so that ambulances were free to go on. But the pressures that are across the system has simply made that not possible. We do, however, have an arrangement where we can release people, and I'll ask Rosie just in a moment to pick up the detail of that, and also to say about some of the discussions we're having with trusts about alternative arrangements. The last point I was just going to make about the rural areas, we consulted over 2 years ago on a new ambulance clinical response model. We did do an equality impact assessment of that, and coming out of that, we've introduced new response standards that are intended to ensure rural areas are not disadvantaged. Before that, our targets, if you like, for responding were just an average, and the average could be heavily skewed by good performance in a densely populated area versus a rural area. On the back of the equality impact assessment, we have now got targets that there still are average, but there's also 90th centile, and we can only achieve the 90th centile if we're providing a good response right across the region, including in rural areas. But we're currently not able to do that or even come close to it because of the resourcing issue. If we need an extra 320 staff to meet those standards, that's a massive uplift both in staffing and budget. But our intention is to ensure rural communities get as good a response. And we've also got other arrangements such as working with community first responders and so on. But in the interest of brevity, I'll stop at that and ask Rosie just to say something, and again, maybe Rosie to keep it brief, about how we make sure ambulances are released for urgent calls and the alternative arrangements?
Yeah, so thank you, Michael, and thank you, Carol. So we have an arrangement across all emergency departments whereby if we get a Category 1 call in, which is obviously an 8-minute life-threatening response required, and we look within our control room and see that there's nothing currently freely available and the nearest resource is waiting outside an emergency department, we have arrangement with all trusts whereby we will phone into the resuscitation room on what is called their standby phone, or their red phone as I call it, and it is manned 24/7, and we give a very clear message. We have a cardiac arrest call in your locality. The nearest resource is outside your emergency department, and we're requesting immediate release of a crew. And then the staff very promptly try and make space within the department to move a patient in from an ambulance that frees up a crew that we can respond to that 8-minute 999 call. And just in relation to the SAIs, just to kind of to give you some update on that as well, and the work that we're doing with some of the trusts. So in relation to the work we do with the No More Silos regional group, one of the actions from the 10 key actions that were identified was that we would ask the 5 larger emergency departments in the first instance to have dedicated ambulance handover zones that would be available 24/7 for ambulance offload, so we could free crews. It's fair to say trusts have been challenged in the various development, and they are all in different stages of development to get a resolution to that. But that's a work in progress, and we're working very closely with our trust colleagues, understanding the challenges that they face. And your comment in relation to patient outcomes and poor patient outcomes and having an assurance, I'll just refer back to the serious adverse incident mechanisms that we have in place, and that is absolutely escalated through the board and the Public Health Agency. So it's quite a detailed process.
Okay, thank you. So going then, actually I had Pam, I had your name down, then I missed it when I went through that last, so I'll go back to you, Pam, and then I see an indication from Alan. So Pam, please, first. Thank you.
I will forgive you this once, Chair. No, listen, a lot of the questions have been asked already, and I wanted just to thank you, Michael, and the panel for taking time to engage with the committee today. It is really important. And obviously, ambulance staff, paramedics, and those manning emergency call and control operations are at the coalface of unprecedented pressures facing our health service. So we're just to say that we are indebted to your skills and dedication of the Northern Ireland Ambulance Service. We also fully recognise that securing better outcomes requires systematic change, and that can't be achieved by the ambulance service alone. So I suppose just in terms of commentary, if you want to make a comment, I would be interested to know what you think the Minister should be prioritising in terms of no more silos and changes to urgent and emergency care. So if you wanted to comment on that, and then I don't know if you have any information you could give us on what pathways are available to paramedics, because we know that paramedics do fantastic work, but they don't necessarily have to be placed in ambulances either. They can be elsewhere within the health service. So if you wanted to make a comment on that, thank you.
Yes, thanks, Pam. In terms of areas for prioritising, I certainly think that the No More Silos action plan that the Minister has published focuses very much on the right areas. It's about alternatives to emergency departments. It's seeing who's appropriate for an urgent care centre. It's about planning unscheduled care, people phoning first, etc. But you'll not be surprised, and I do have a responsibility in my role to look across the entire system and to be part of supporting the entire system to do the right things. But you'll not be surprised that I've got a particular interest in the action within No More Silos about prioritising the timely handover of patients, those handover zones that Rosie has referred to. Sorry, what was the second part of your question?
The second part of my question was around pathways.
Yeah, sorry, I was writing things down and I missed that. Yes, we've seen good progress over the last number of years on the ambulance service being able to do things other than take people to emergency department. If you go back 10 years ago, that was the only option. Ambulance service went out to sick people and brought them to hospital. As our skills have developed, our staff skills have developed, we are able to do much more for patients at scene, either to resolve their condition or signpost them elsewhere. And as a result, we now don't convey about 25% of patients that we go out to. We don't convey 25% of them to an emergency department. That's good for everybody. First and foremost, it's good for patients. I've yet to meet a patient who wants to go to an emergency department, so suitable alternatives, they are keen. It certainly helps the wider system, given the pressures in hospitals and in emergency departments in particular. And it is good for us as a service that we are not joining acute and emergency department and waiting. So we're very keen to increase that level of non-conveyancing to ED. As I say, it's currently sitting around 25%. We've got a range of care pathways, and again, I'll ask Rosie to mention some of them, but they're in areas like falls and diabetes and so on. There are areas we could do more if we had access to more care pathways, and also about them being consistent. Our staff do, as we've already said, respond to calls in different divisions. If they happen to be the nearest call, they're sent. If there's a different set of pathways in one trust area than in another, that can make it difficult for our staff to know exactly what's available. So an increased number of pathways and consistent, and I suppose the one in particular that I would highlight that would make a big difference to everybody, not least to service users, is somewhere more appropriate for people in acute mental health other than emergency departments. So that would be one that we could really collectively make a big difference to some patients. And this isn't just about easing pressures, this is about doing the best we can for patients. But Rosie, anything you want to add?
I think just things in more silos work, just very briefly, some of the other pathways that we're working with trust colleagues, that if they could expand their capacity. So for example, focus on out of hospital care provision, and I use acute care at home as an example in that regard, whereby with a very good service in the community, fairly high acuity patients can be cared for very well in the community, and as paramedics, our crews can refer directly to those services. Some have more capacity in some areas than others, but alternative care pathways and increased ambulatory care provision, whereby we as an ambulance service can hear and treat or hear and refer a patient to avoid that conveyance, so the patients are treated in the right place, which isn't always an emergency department, as Michael has said.
That's great. Thank you very much, and I wish you well. Thanks, Chair.
Thank you, Pam. And Alan, go ahead then, please.
Thank you, Chair. Michael, I certainly don't envy the task of yourself and your team at the moment with those staff shortages that probably come at you at very short notice. I was wanting to ask about the first responder system. Is that still working for you, and is it still a priority, even with staff shortages, to maintain that first response service? And last year, I think it was, we talked about the possibility of bringing in just drivers to drive an ambulance along with a paramedic, but I think at the time the practice was that it was a paramedic and a qualified technician had to be on board the vehicle. And then I think later you reported that you had got the assistance of some drivers from the other emergency services, even the police and the fire brigade. Now I understand that you have to be careful not to compromise the safety and well-being of patients that are in your care. But are you still using drivers from other services, or is it something that you would continue to give consideration to? Just to try and increase or to decrease the waiting times and get people to hospital in a more timely fashion. Thank you.
Okay, thank you, Alan, for both of those questions. The Community First Responder Scheme remains a priority, and they provide a very valuable service. At the very start of the pandemic in March 20, it was one of the areas that we reluctantly had to stand down, and that was because at that stage when it was all new in terms of the level of risks and the challenges around protective equipment, PPE, that we could not oversee that those community first responder schemes had access to appropriate PPE, and we had to stand them down. So our control room dispatched them they alert them to calls in their area, and we didn't do that for quite some time. That has been returned, though. They are back up and running. We are using the community first responders scheme and groups, and I would really pay tribute to the dedication of those individuals who are volunteers who give up their time to do it. We have a small team of staff within the ambulance service, our community resuscitation team, who provide training to, for example, now to teachers, to train CPR skills to undergraduate teachers and to children. They take the lead with training our community first responders. And actually, it's something we are probably likely to look at how we can further develop over the coming years. What other calls could they go to so that they remain a priority? The drivers' issues is a strange one, Alan, because I know even from your question there might sound a bit of a contradiction on what I've said and what we do. It is a case of needs must. So our ideal response would not be to send one clinician with someone who is simply a driver. There are some calls that would be adequate, but there are many calls that it would simply be insufficient to provide the level of care, and there's the need for two clinicians, particularly in things like CPR. If they arrive on scene and somebody has to be doing the CPR while somebody else is preparing, for example, drugs and so on to be administered. It's certainly the case in road traffic collisions, a whole range of areas where they need clinical skills, and one person on their own simply would not be able to respond. But as part of our escalation plan, we have to get to the stage where there's a balance between what is what we would like to do by way of a standard and what's the best thing we can do for the many. So we have been very grateful at various stages during the pandemic when we have colleagues from both the fire service and the PSNI in working alongside. We do provide them training, but they work alongside our colleagues really to allow us to split crews and have more ambulances out, and that remains something that we can request at times, and they can't always do it. There are some times when we need this ties in with particular pressures in those services, for example, around the July time. When they simply have so many pressures of their own, they were unable to help us. But on most occasions when we ask, they're quick to respond. And I suppose that the ongoing conversations I mentioned earlier with the fire service will look at how we can do that on a more ongoing and planned basis. So we're very grateful that they're there to help us when we need it.
Thank you.
Okay, thank you. And Michael, I want to thank yourself and your team there that have attended committee this afternoon, and also to extend the committees, and it's been mentioned by several members, and I want to reiterate it, our appreciation of everything that ambulances staff do in common with our entire health and social care workforce family. They're under huge and unprecedented pressure now for a sustained period of time, and we do fully understand that they are struggling to cope, but continuing to cope and going the extra mile often to do that. And I do want them to know that we understand that is happening. It's not going unnoticed, even though in many ways we're not able to bring immediate solutions. We do realise that staff are stretching themselves to cover all the demands that are on their time. So thank you. Any final words from yourself, Michael, before you go?
Just to thank you for those words, Chair. I will find a way to communicate that to our staff, to let them know that's been passed on. I appreciate those comments, and also from other members. And just apologise again that although you heard their voices, you were not able to see Rosie and Maxine due to our difficulties with technology at this end. But thank you for your continued interest and support in our service. It's much appreciated.
Okay, thank you, and thank you for that, members. So I think again there's a number of pieces of information that have been committed to being sent forward, and the clerk will have a note of that. So if